case study, Pediatric Critical Care. Where have we been and where are we going? You are a Pediatric Critical Care Fellow, rotating through two different eras, the 1985's PICU and the 2028 PICU. You will manage the same patient C in both settings using the resources and knowledge of each time. Patient presentation, both eras. Patient, Ron, 6-year-old boy. Presentation, acute onset respiratory distress, fever, hypotension. Vitals on arrival. HR, 165 BPM, BP 7040 min, MHG, RR 45 min, SpO2 86% on 15L, NRB, temp 39.5 Darison. Exam, mottled skin, delayed cap refill, drowsy, diffuse crackles on auscultation, labs, pending, WBC elevated, lactate 5.5 mol sodium, PICU of the past, 1985. Your tools, basic ventilators, pressure limited, no volume guarantee. No bedside ultrasound, basic pulse oximetry, early models. Invasive arterial line is for BP monitoring. Paper charting. Empiric antibiotics without rapid diagnostics. Early ECMO programs, highly selective candidates. Limited understanding of sepsis pathophysiology. Family visits limited to a few hours a day. Your actions. IU1, airway and breathing. Intubation with direct laryngoscopy. Vent settings, pressure control, no synchronized modes. ABGs manually drawn and sent to lab for results. 2. Circulation. Peripheral IVs, eventual central line placement. Fluid boluses guided by BP and clinical signs. Dopamine infusion for hypotension. CVP monitoring, a central line to guide fluid resuscitation. 3. Diagnostics and management. Blood cultures sent, empiric antibiotics, ampicillin plus gentamicin started. Chest x-ray ordered, film processing takes time. No point-of-care ultrasound, can't evaluate fluid status quickly. Sepsis management focuses on fluids and vasopressors. Limited sedation options, high-dose benzodiazepines. 4. Communication and family. Minimal family involvement in rounds. Family visits restricted. Decisions made by medical team with limited shared decision-making. PICU of the future, 2020. Your tools. Advanced ventilators with AI-driven lung protection algorithms. Non-invasive cardiac output monitoring. Point-of-care ultrasound, POCUS, standard on every bedside. Near-instant pathogen ID with molecular diagnostics. Personalized antibiotic dosing, pharmacogenomics. Continuous non-invasive BP and oxygenation monitors. ECMO is widely available, portable, and started earlier when needed. Sepsis care bundles driven by predictive analytics and biomarkers. Family integrated care with 24/7 presence and decision-making. Your actions. 1. Airway and breathing. High-flow nasal cannula with automated oxygen titration initially. Intubation with video laryngoscopy if necessary. Ventilator automatically adjusts for lung protective strategies based on lung ultrasound and compliance monitoring. Continuous capnography and SpO2 with AI alerts for early decompensation. 2. Circulation. Non-invasive cardiac output monitoring and POCUS for fluid responsiveness. Balanced fluid resuscitation guided by dynamic markers. Early initiation of norepinephrine via peripheral line. Personalized vasopressor and inotrope therapy based on real-time biomarkers. 3. Diagnostics and management. Rapid molecular testing confirms pneumococcal sepsis within 30 minutes. Antibiotics targeted based on resistance profile and genetic markers. CRRT or ECMO initiated earlier if needed with portable systems. Early mobilization, even while intubated, thanks to improved sedation protocols. Dexmedetomidine, minimal benzodiazepines. Neuroprotection protocols in place from the start. 4. Communication and family. Family present and involved in rounds via virtual or in-person attendance. Shared decision-making using predictive outcome tools. Holistic care with psychologists and child life specialists integrated from day one. Focus on long-term outcomes, early rehab, cognitive protection, nutrition optimized from the start. Outcome in 2035. Ron spends 4 days in PICU, minimal sedation, mobilized by day 2, extubated to high flow by day 3, discharged home neurologically intact, with follow-up coordinated via telehealth.